we are going to have site-specific head and neck. Dr. Mohan Lee from UT Southwestern will give a talk today. And just like other sessions, you can put the questions in the chat box. After each Zoom, we're going to go through some questions. We might not be able to do all the questions because of time limit. And we'll try to stick with the 1.5 hour time slot. So Dr. Lee, I think you can start. Thank you.
Thank you, Sua, for the introduction. And it's so nice to see in the chat that people coming from different areas of the world, and such a pleasure we can present our work here. Today we are going to talk about the head and neck plan quality evaluation. So basically, we will follow the same outline as other talk. We'll first talk about the patient assessment and MD intent, and we'll talk about the simulation, treatment planning, communication, and the deviations. And most of the effort will be putting in the second and third part with a lot of examples to show like acceptable or not acceptable plans. Patient assessment. So the same as other treatment site, you do want to review patient's medical history and the consult report to have the correct information to know what MD intend to do for the current treatment. And for head and neck treatment, the intent can be definitive, post-operative, or palliative. So commonly treated with multiple dose levels for the head and neck treatment, the gross disease need to get higher dose, and the lymph node will get different dose based on how its risk to malignancy. So the variation will be based on the disease site, stage, and if patient get a chemotherapy or not, or if patient has prior radiation therapy. And chemo RT has been super popular and shown to be very effective for the head and neck treatment. So this is gonna be something unique compared to like SBRT course you've been to like a couple of weeks ago. So a lot of time our head and neck treatment will need to be coordinated with the chemotherapy. That's also one of the unique problems we will talk about later on, how to coordinate the treatment, when to start the chemo, when to start RT. And physicists do need to know some basic knowledge about head and neck treatment. And here I cite a review paper. This paper gives an overview, and it's not most in-depth paper, but it's a pretty good one for you to get a big picture of head and neck treatment. And then our head and neck doctor kindly put together some of the more specific and useful guidelines for MDs, physicists, and everyone in the department. So the ones you can click link and download the document, I provide a link here. So you can go ahead to download the document if you need it. And this one, NCCN guideline will require you to have account in order to log in to have access to the report. But all other ones are publicly available. You can just download. Moving on to the special considerations, implement device, like other treatment sites, we also need to care about for the head and neck treatment. They are usually implanted lower than the area we are treating, but then still something we'll need to address if patient has implemented device. And head and neck specific issues are more at the dental implants and also orthopedic hardware. For example, if patient is more at a palliative setting, they may have some hardware in the neck, and that can be something you really need to be paying attention to. And commonly, the dental implant materials are the titanium, and there are some other material can be used for the dental implant. But fortunately, they are usually small in volume, so not as a problem as the hip replacement for the prostate. But when you have patient with a lot of implants, you do want to remind your doctor to talk to the patient if they can do something before the treatment, especially if you are treating the lesion in the oral cavity. So in our institution, there are scenarios happen. Patient has a lot of work done for the dental, and then treating in the oral cavity. Our physician suggests the patient to remove all those hardware before we start the treatment. So that's something can be coordinated. If you really need to treat the area with very highly accurate dose, that's something when you, as a physicist, or when you are reviewing the patient's chart, you need to think what we can do to make this treatment more robust and more helpful for the patient. Another thing that's more head and neck specific is the claustrophobia. That's a common issue. But for head and neck treatment, there are options like open face mask can be used, and that will really help the patient to feel better when receiving the treatment instead of covering the entire face. The prior radiation handling is usually the same as all other treatment sites. You do want to know when the patient gets irradiated, how much dose being delivered to the area, if there is overlap with the current area you are treating. And it's already a standard of practice in a lot of institutions that you contact the prior treatment institution to send you the CT images, DICOM dose, structure, and plan that you can import to your TPS, do a good registration to sum the dose. So those are highly recommended. Moving on to simulation. So for head and neck setup, there are options of mask you can use depending on where you are treating, if you need to treat the neck volume or not. So there are 3-point masks and there are 5-point masks that emphasize the immobilization in the shoulder area as well. A lot of head and neck treatments, usually you need to treat the neck node. So in the US, it's more commonly seen the 5-point mask being used for the head and neck treatment. And one more thing to emphasize is when you are treating the neck node, you do want to make sure you have good immobilization of the shoulder, and you do want to make sure you get the shoulder out of the way for the treatment. In this way, you can reduce the dose to the shoulder. And there are things you can do from sim all the way to plan and finish. At the simulation time, you can have this device that patient hold the strap here that will help to lower the shoulder and provide the stability of the position. But again, when you use such a device, you want to make sure a patient can hold it in position for 10-15 minutes during the treatment, so we can reproduce it every day. Because a lot of time, patient will try to do a very good job at the sim, but when they are at the first fraction treatment, they sometimes can feel tired, or if as the chemotherapy goes, they may be weaker, not in a very healthy condition. So you do want to make sure the way they grab it is something they don't put too much stress into it, and it doesn't make the patient feel tired. And this is a good small device to help give you better setup condition for planning. Headrest. So we do need to select appropriate headrest to immobilize the patient's treatment, and that will also help to fix the anatomy better for planning, especially when you try to treat this chin or the larynx area. You do want to have the patient tilt a little bit, and there are a lot of options for the headrest. In general, we do recommend to stick to more standard setting of the headrest. There will be patients that are not comfortable. They want to have cushion or pillow add on top of this headrest, but you need to be careful when we want it to be comfortable enough so the patient won't move, but we don't want it to be too comfortable that they can easily wiggle their head. So we don't usually recommend to add any kind of personalized device on top of this. And there is a new type of device use aquaform and a new type of head holder that I don't include here because it's also not a common practice in the US yet. Yeah. And one thing to remind everyone is when you use the mask and then the headrest, you do want to be mindful of the bolstering effect of those materials. An example is like here, it's 5-point mask, and there are some portion of it is solid, and that's kind of emphasize the immobilization for the patient, but some other places are open. Yeah, and there are options to be more closed up, but you do want to make sure this doesn't cause you bolstering effect. And this also related to how deep your tumor is, where your high dose is. So be careful what kind of mask you are choosing for the treatment. And when you review the simulation setup, you do want to make sure you review the variable external anatomy, such as shoulder positioning. And you also need to review if you need an ancillary device and evaluate the setup can be reproduced every fraction. A good example is bite block. We know if we are treating the mouth and if patient has a bite block, we can push the tongue out and open up space, and that can give us better dose distribution in the TPS when we see it. But the problem is, can you reproduce the bite block location exactly the same way every single day? That highly depending on the skill of your tech at the CT sim. So it has to be something patient can bite on and patient can reproduce the bite every single day easily. And it cannot be too big. Sometimes people will be overly emphasizing it has to open up the space, make it too big, and patient doesn't feel comfortable in the upcoming treatment. They just cannot tolerate it, or they tend to push the bite blocker away to make them feel more comfortable. So you do want to make sure this is something practical enough to reuse for 35 times, okay? And placing the bolus at the seam is actually a good strategy for institution if you don't have 3D printing 3D bolus, and that also help you to know what you can reproduce at the treatment. If you place the bolus on the patient and scan with it, you're gonna see how well how good the bolusing effect is of your bolus created at the seam. But you do want to make sure you can reproduce the same setup and take good picture of the bolus location, what is it made of, such type of information, okay? Moving on to the image quality. So for head and neck imaging, the artifact is most common problem for patients because it's common. Over 80% of the patient will have something in the dental work done in their mouth. And there are common ways to handle it. Like Philips has the OMR scan that reconstruct the image in a different way to reduce the artifact effect in the image. And then similarly, in Siemens machine, there's the IMAR also doing the same thing. So first of all, like in our clinic, OMR scan is kind of default to all head and neck patients, regardless patient has the dental work or not, but it's just a protocol you can easily use, and you don't need to think I need to add it because it's already customized in the standard protocol. You just load it and run it. And you do want to make sure your FLV is smaller or adequate to balance between your image truncation and your image quality. It doesn't need to be really small to make the best image quality because you need to think about for head and neck treatment. Oftentimes we need to treat the neck area, but you do want to make sure it's a good balance between your FOV and your image quality. And all the critical OARs and those volume constraints are they fully imaged. So the border of the simulation scan is very important. And similarly, we recommend you to go 5 cm above and below the target. And then think about the image artifact. And the best way to see is after the scan, really look at the image to see if they are useful for the treatment or not. So if something is not useful, we can suggest patient to get other image modality to help the target delineation or do something instead of let it go to the next step and come back and say, well, this image is not even useful for the planning, okay? So multimodality imaging like TAC or MR, they are oftentimes used for head and neck cancer to help the contour. And ideally, we want them to immobilize the same way as how we do in the radiation oncology, at least like neutral head. But a lot of time they are done in like diagnostic department or even outside institution. And if this is done in your own institution, just different department, it's highly recommended to give them a general guideline. If patient may undergoing the radiation treatment, scan in a neutral position and don't let their head tilt. That does help them to get a better image when we receive the diagnostic image. Instead of like tilted head, it's just harder to handle. So if that's within the same institution, this actually can be improved by communication with like radiology department. Image transfer, simulation scan, and multiple image sets acquired at the CT SIM will be sent to the TPS. And usually for head and neck, there will be contrast image, non-contrast image, and OMA scan that has lower artifact. And PET image is something I want to emphasize. When you go on the PAC system or receive the PET image, there are usually multiple series associated with them. Some are actively corrected, some are not. So you do want to pay a little bit more attention on the DICOM header of the PET image, so you are getting the correct SUV number to help the doctor to contour correctly. And it is important to label every series to clearly convey the information for the physician to contour. And this can be done manually. You look at the header and change the name in the treatment planning system. The MD can easily know this one is contrast, this one non-contrast, or this is ORMA. And there are a lot of scripting maybe available that you can just run a script to rename all the images when you do the import. DICOM header usually contain very useful information, including the acquisition date and slice count. And that's something we usually check when we import an image. We do check, are we importing the right PET image? Because patients getting radiation therapy, they usually have multiple previous scans, like diagnostic scans. You do want to make sure we import the most appropriate scan. So they rely on good communication with the physician to know which scan is the most crucial one to import. And second is also our sanity check. If the physician tells us, I want to use the PET scan 6 months ago, you do want to ask, why can we get a newer? And do you think it's stable enough? So ask question when you feel like, there's kind of a bit old image, or the image doesn't look quite right. Okay, but a lot of time we do, well, this is our standard practice. We do check the image, the DICOM header, to know we get the right image in. Here comes the first Zoom question. So during the head and neck stimulation, which technique can be used to reduce the metal artifact caused by the dental filling or implants?
I'm sorry.
You opened the
Hold
floor.
on. I opened the long Zoom. Yeah. I'm sorry about that. Hold on, please. Let me redo.
No problem.
The launch button is not available. I'm sorry about that, but I think I see a lot of answer.
Oh, yes.
Headroom.
It was not set up correctly.
Yes,
yes.
Yeah, number 4 was on the top, so I launched that incorrectly. I see a lot of chat room answers. Most of us are answering number 2. So we'll move to the next one. Yes, thank you.
Yes.
Sorry about that.
This is awesome. You guys are great. And let's move on to the treatment planning fun part. So first thing to talk about is head and neck contour is kind of art, because a lot of time our doctors need to navigate with different type of images, and they are not done in the same way. Like in head and neck treatment, we usually let patient have neutral head or sometimes tilted a little bit so we can open up the space better for planning. But a lot of the PET image, they are getting like this or this. So the neck angle is crucial. So when we prepare the fusion for the doctor, we do want to make sure we clearly communicate to doctor where we fuse with. Okay, for this example, the neck angle is different between the CT sim and the PET. We ended up doing 2 different registrations in order to facilitate good contour. Registration 1, we focus on the neck nodal volume, and then registration number 2 is the gross tumor volume. Okay, so this is a common issue. You want to first evaluate accuracy of image registration for your intended purpose, and you want to verify that correct images were registered, like pre-op versus post-op, or the date of the study, like I mentioned in prior slides. And you also need to think about the clinical impact and the uncertainty of the registration, selecting the PD margin. So when we send the contour task to our doctor, we do document, like, here's how I register my image. Like the next position is different. I cannot get everything in one registration. The one you are seeing right now only take care of nodal or the primary target. So the MD will clearly know what to do. And oftentimes the problem will happen when a new resident follow the MD that didn't review carefully. But when we get the volume back before planning, we do double check. Does this contour also matched up with the tissue we can see on the CT scan? Okay, so make sure good registration and good communication to your doctor. What do you register to, so he can know how to act on it. So he can contour the first one, rotate, and get the second one down. All right, and when you come back, you will need to double check it. And this is the planning lecture, not the contour lecture, but our doctor just kindly provide a lot of contour guidelines for the OARs and the targets. So I have them, the icons here. If you want further reading, you can go read more about contour. Okay. And there are other general guidelines like Atlas you can find online. And then nomenclature-wise, we do want the standardization for a lot of reasons. It's easy for people to follow, not to forget. And it's also easy to check or create an automatic check based on a given nomenclature. And TG2633 is one of the guidelines people commonly use. And that you do want to make sure you contour everything you need and you don't miss any of the target or the OAR. And especially if you follow certain guidelines, do compare what the guideline asking for and what you have in your plan. And then verify the laterality. An often mistake is like priority left and right, especially when people are just contour several cases in a row, this can be messed up. And you want to compare the target volume and what the patient consent for the treatment to make sure it's the right treatment. Because especially for patient with re-radiation or a patient has multiple lesions to be treated sequentially, you do want to make sure you are planning for the right one, because sometimes the sequence matters, because for certain sites it may be treated with chemo RT, sometimes some sites are not. So we want to make sure you get the sequence right, you are treating the right target. When there's a problem or you are not sure, just ask your MD or the planner. And on the right, I do want to show the example. Like there are a lot of contours, auto contour tool or AI contour available in the market now. Some of the new TPS also equipped with like AI contour for you. So a common pitfall of this system is their contour protocol may not be the same as your institution's contour. For example, in this example is the Ethos 2.0 auto contour. The AI contour is short as a shorter spinal cord contour compared to the MD institutional contour. And similarly, in the prior slide, the AI contour was trained by public data set, which is following the NRG guideline. And then the institutional guideline is different from that. So you do want to make sure even you have auto contour to help you doing a lot of things. And usually that's the case for head and neck contour. People use a lot of auto contour, but you do want to make sure you are not just running the contour, you also double check if this fits what you need for the planning, okay? And then you do want to identify if there's missing slides for contour, especially for the auto contour. AI contour is can also sometimes miss one slide or two because it's identified based on the imaging features. So you do want to make sure after you get the contour, you look at if you are missing slides or stray pixel that need to be cleaned out a little bit, okay? So if everything is tied up, okay, yeah. So we can move on. The next is the contour margin. There are different protocols to define different treatment margin for head and neck, but in general, margin need to be consistent with your institutional or the clinical trial guidelines you are following, and then margin need to be implemented correctly to the planning system. Like a symmetrical customized margin will deserve extra sanity check. Like in our institution, we do have our doctor to type out what margin they use to generate the volume. So that will help us to check if the volume be generated correctly. A common error is really the cropping. So head and neck target usually will be cropped from the skin or cropped from body plus 3 millimeter to kind of balance your coverage and the hotspot on the skin. And you do want to make sure your body contour is correct. Here is one clinical example. So this is the volume we receive for treatment planning. And the planner or physics, we noticed that the tumor is so close to skin, it doesn't make sense as a general head and neck planning. We know there are some exceptional cases, but this is a general case why this happened. And then we further find out the auto contour actually pick up the mask as body. So when MD use this green wrong body contour to make the target volume, it cropped from the mask, not cropped from the skin. That give you a wrong PTV. hard to plan and hard to treat. And so we further correct the body contour to match the soft tissue, the skin we can see here, and regenerate the PTV. So you can see how different they are. Okay. And this is a common pitfall for the head and neck cancer. So, well, in our practice, we do have our planner review the body contour before we send the contour task to the doctor to start the contour. So this green ideally should be picked up at the time you do the import and prepare for the doctor to contour. So similarly, any external contour, you need to review the supporting structure, including couch or the S-frame that's supporting the mask, are accounted in the calculation. You want to make sure your body contour includes a bolus or ancillary device, and you need to set appropriate window level setting in order to see them. Here shows one example. At the seam, the MD placed some bolus strip on the neck, and then this is how it looked like in the treatment planning system. Patient scan with bolus, but when we start to plan or finish the plan, I cannot remember when exactly, and we found the bolus is actually not in the body, and that's what we see when you open the TPS. The window level was set to this window level, so that's why it got missed. Because we were looking at it and like, well, where is the bolus? And then when we set it to a long window level, we were able to see the bolus and correct the contour accordingly. So from there, we update our standard of practice. When they do the body contour, they need to set it to the long window before they finish the task, so they can double check the bolus being included for planning. Okay. Density override. So density override are common things we do in head and neck planning. The high Z material usually gets saturated, and then you can set up an appropriate window level to stretch out those high Z material area and contour them and assign the density. And this is a lot of TPS will do this automatically for you, will detect the high Z area, or they will provide you a tool to filter and find those high Z material. And contrast or wire or other material present during the simulation not presenting at the treatment, you do need to consider to density override them. I know the contrast override in head and neck sometimes can be painful because a lot of vessel will be bright, but they are necessary because it does cause the dose perturbation. So a more favorable way to do is you get a contrast scan, you get a non-contrast scan, that will save you a lot of effort to correct this. And here I show a more extreme example. So this is an example that during the physics plan review, we see the patient has a lot of dental work in the mouth area, and you are treating right here. And then we further look at check the contour to verify the override, and we'll notice there is no density override being performed in the soft tissue here. Okay. And then we further recalculated the plan with density override, and we found the coverage is bad. It got compromised. So this case at the end being replanned with density override. Okay. So part of your chart check, you do need to review the density override for the head and neck cases. Question number 2: which one of the following contour issue is the most severe to contribute to an unsafe plan? 1, missing one slice of target. 2, bolus not included in the body contour. Number 3, missing the spinal cord contour. 4, stray pixel of the OER contour. Which one is more severe?
I launched it correctly this time.
Yay.
Okay, we'll end the poll.
Yes. Okay. So the answer is number 3, missing the contour of spinal cord. Because missing the bolus is, yes, you may get hotter plan, but patient won't have life-threatening complication. But if you don't contour the spinal cord, you may end up with overdosing the spinal cord. We just had this happen this week and been picked up by the physics chart check that we are treating the patient in the nasal area, and then the planner forgot to constrain or contour the spinal cord because they are thinking, oh, we are treating up here. So they put a lot of effort to push the brainstem dose, but did not pay attention to the spinal cord. Ended up spinal cord was at 51, almost violate the guideline of 52.8 grade. So this is super crucial. In that case, actually ended up being replanned. So you do want to turn on your bedside view, make sure you have your critical OAR, spinal cord, brainstem, and optical nerve all contour in the area you are treating and above and below 5 centimeter. Okay.
We have a couple of questions. One
Sure.
question is, how do you choose SIB versus sequential?
Yes, that's a good question. So SIB is actually preferred in general in the institution to reduce the amount of planning effort. Because sequential, it requires 2 plans, and usually our planner will spend more time to just split the objective between initial and boost. So nowadays, at least in our institution, we prefer the SIB plan. There are very few cases due to patient's clinical scenario, like patient is really in a bad shape, or they don't think the patient can get such a high dose to an area at the beginning, and that will be the special case, and we revert back to do the sequential, not SIB. Otherwise, SIB is a kind of general practice in our institution. But I'd like to know about what Duke is doing, Sua.
It's for physician's decision, but nowadays with the VMAT, a lot of times I see SIB more. It is, yes, I'm a physicist, it's clinical judgment, and standard is sequential, but SIB is a little bit more rigorous because we can be actually done quicker.
Yeah.
Yeah.
Right. So I think in our institution, we still keep some sequential. It's really for special case and for adapt. That's a different consideration, not because of patients, because it's faster to adapt simpler target. Otherwise, it's mostly SIB.
Okay, thank you.
Thank you.
Other questions are answered in the chat room, so we can continue. Thank you.
Thank you. Well, we move on to the beam setting. Similarly, for the head and neck, there are a lot of variation of head and neck cancer, and you can treat with photon and electron, especially when you're treating superficial tumor. But here I focus more on photon because the electron planning are relatively simpler, and when patient treat with electron planning, it's usually 2 grade per fraction, and there are a lot of chance you can correct the plan if there's a problem. It's usually just 1 port. And for us, we only treat very superficial tumor or the parotid lesions with electron. Otherwise, most of the cases, especially with nodal involvement, they're definitely treated with photon. And given the complexity of the plan, IMRT, either static field IMRT or VMAT, are most commonly used. And then the beam arrangement is one thing I do think we need to pay attention to. So head and neck are hard to plan. So things like this, you only have ipsilateral lesion. When we talk about SBRT a few weeks ago, we said we can just use half arc to treat this half. But with head and neck, you do need to shape the dose more, pull the dose to different direction. So you do want to make sure you have a little bit contralateral contribution to improve your dose conformality, and also create a room for optimizer to pull the dose to different direction. So we do usually, even for ipsilateral lesion, we do go a little bit more beyond the midline. Okay, there's something different from some treatment site, kind of head neck specific, because you just have so many OAI you need to take care of. So you need to create room for the optimizer. And more than often, we do use the full arc for most of the cases. Yeah. But if patient is just single side for the entire volume, we will do more like this type of setting. Okay. Again, we do want to make sure we avoid the shoulder. So shoulder won't kill the patient, but shoulder will make patients suffer quite a bit after treatment. So Sua gave me a lot of good example to demonstrate how this can be done in the beam arrangement and the optimization. So saying that we already showed the picture, you can pull the arm down to create a room and get it out from the treatment area. But there are more you can do. You can contour the shoulder, like here, left and right in contour. And then in the optimizer, most of the optimizer, ray station, eclipse, and monocle, they all have feature and to turn off the beam LED. So you can turn off the beam LED in the optimizer, tell me if you see this, do not put the beam onto this exit dose, okay, or you can also turn off the exit dose if you want, but usually turn off the entrance dose is already quite sufficient. Furthermore, you can also, from your jaw setting, beam arrangement, you can also emphasize you don't go beyond your target area. And then you can also set your collimator angle differently. So in that way, you have MLC to collimate the beam and to modulate beam a little bit better to avoid the shoulder. Okay. Moving on to the deliverability, head and neck usually treated with coplanar manner. It's very unlikely we treat with non-coplanar. In our institution, we only have like some of sinus cases. We really need to put like vertex beam to reduce the dose to the eyes. But most of cases are coplanar. So if you do have non-coplanar beam, you can run it by manual like dry run or CT guided clearance mapping or surface guided clearance mapping. Those are all super helpful tools. And this can be a more common question for head and neck because the newer machines available like Halcyon, they are 6SS of beam. They are not flattened beam. But there are studies already shown, flattened or not, it doesn't really impact your beam plan quality at all. And I provide one of the study, but there are multiple studies showing that. Because it's intensity modulation anyway, so it makes no difference to the optimize just to modulate a little bit more to the shoulder of the beam. Okay. And then you do want to make sure similar principles on other treatment side, you do want to make sure you have MLC to conform the target and block the healthy tissue and avoid the 0-degree collimator angle. And you do want to leverage a collimator angle to facilitate the spinal cord or dose sparing in the middle part. Let me show you one clinical example from the beam side view, okay? So background, the patient is prescribed to receive SIB treatment to bilateral neck node. And then the dose to the neck muscle seem to be unnecessarily high. So there's nothing really wrong with this point. It's clinical treatable, meet all the criteria. But just why do we have this dose cloud here? Is this necessary or not? And further looking into the beam arrangement, the planner try to alternate the collimator angle to have 30 degree, 10-ish degree, and 30 from the other direction. But then it's just not perfect. So how to fix this is we change one of the collimator angle to 90-ish degree. They'll effectively cut down the dose in the middle. And this is extremely helpful for head and neck cancer when you have the spinal cord in the middle, larynx and oral cavity, and then you do have the hardy gland inside, 30 degree will help you. So you do want to make sure your collimator angle is defined to facilitate the dose sparing to those OARs. And just by simply changing the collimator angle and re-optimize with exactly the same thing, you are able to get a better plan. So nearly no effort. So I also see in Sua's example, they also have 90-degree collimator angle zero, and that's also the standard of practice here. We do have at least one arc being 90-ish degree to facilitate those sparing in the middle area. Beam side view, you do want to make sure you review the beam side view for proper target coverage and excessively small aperture that do not conform to a target, because those small aperture does not really contribute too much to your dose, and it does increase your uncertainty to fill the QA. And you want to maximize the degree of freedom to modulate from different direction. Like I mentioned, you want to have 30-ish degree or 45 degrees to help you with the shaping of the party glandules. And you also want to have 90-ish degree to help you close up the dose in the middle. And check the MLC travel is adequate for the field shaping. So this is important because you do want to have the variation of angle, but you do want to make sure you don't put a crazy angle that wastes half of your beam and your MLC being over can only move like take care of part of your tumor, because that's just not helpful. You rather change it to a smaller angle so the MLC can travel a bigger distance and take care of a bigger area. That's just a balance, okay? And MLC opening outside the target may cause the straight PTV voxel, but this usually won't happen unless you push the plant so hard. So you'll try to create a tiny island, put a lot of weight there, try to tend those in a tiny corner. Yeah, the smaller aperture will increase the dosimetry uncertainty. Moving on to the modulation factor. Modulation factor is defined as mu divided by the prescribed dose per fraction. And we do want to check this number to make sure it's within the expected range for the modality. And high modulation factor can result in a poor QA passing rate and loss of robustness of the delivery. Ideally, you will collect your modulation factor data of your site or modality in your clinic, but you can also look up from the paper. When modulation factor is higher than expected, you can consider to replan it or fix the plan by adding the MU penalty. Tell the optimizer, don't give me such a highly modulated plan. Or in Eclipse, there is aperture controller. You can tell the system, don't give me tiny aperture, give me bigger aperture. So there is aperture controller, low, medium, and high you can set to tell the system how modulate you want for the plan in general. And you can do the minimum size segment. That's the terminology used in the Monaco. Similarly, in Monaco, you can tell the system what kind of segment size you are expecting, how many segments, how fine resolution you want for the optimization. And if all this didn't really help, and that means your plan may be pushing too hard, you do want to relax the optimization priority a little bit. Okay, let's move on to the next full question. So for SIB head and neck planning, which one of the following has the largest impact on the plan quality? Number one, 5 static field versus 5 arc. Number 2, beam energy of 6 versus 10. Number 3, dose rate 600 versus 1200. Number 4, collimator angle with or without 90 degree. Okay.
Are you answered? I'll end the pool.
Okay. Oh yeah. So, well, I think both. Yeah. All right. I think I may confuse you guys. I feel guilty for this one. Okay. So, because I keep emphasizing the collimator angle, but I think the answer is actually 5 field arc versus 5 field static field. Yeah. So without arc is probably the second from the 4 of them. So without can make your plan dose distribution to be better. And as I showed in the previous examples, they pass all the OER constraint criteria. It just doesn't look nice. It's not the best quality we can achieve. But then not enough fields is a bigger problem, because that means you may not even have appropriate number of binlets available to shape the dose. Like in this case, if I optimize with only 5 field IMRT for such a complex volume, I will end up with some unnecessary hotspot just because I only have 5 angles to control the dose distribution. Yeah.
But I have a question. So
yes.
If this question was not specifically for SIB, if it was just for head and neck planning, what would be the largest impact to spare larynx or to have the low dose for the cord area? Then number 4 would be the right answer. Is it correct?
Correct.
Okay.
Yes.
Thank you.
That is correct. Yes.
Yeah.
So SIB, you need more. So in general, if you plan SIB for head and neck, you probably need 7 to 9 field at least. Yeah. And then especially if we have 3 dose level. But if that's non-SIB, then collimator angle is the most important. Yes. So you guys did a great job. Thank you.
Thanks.
All right. Moving on to optimization. Okay. So first is target objective. You do want to verify your target has a higher and lower objective, because this is head and neck treatment. Usually we treat big volume. So hotspot does matter for the treatment. It's not like SBRT or SRS, you don't limit or you constrain it softly. Head and neck, big target, you do expect your hotspot to be at lower than 110. So you do want to make sure you have lower and upper. And for simultaneous integrated boost, the optimization structure cropping higher dose level with a margin to cool off the dose to lower dose level is recommended. We'll have a real example to show you. And that will help you to minimize the dose bridging between the high and low dose level. And the goal for maximizing and minimizing the dose to targets are typically stated in the RTOG protocol. Some institutions may have their own limit, but for head and neck, it's pretty much following. All institutions are pretty much similar. You don't want hotspot, you don't want dose bridging between different dose levels. And how technically achieve that? Here's an example. You have the red is the gross tumor volume you want to treat to 70 gray. And you have the green actually include the red you want to treat to 60. So technically, if you don't bleed out, if you don't create optimization structure, you will be asking the optimizer to give a high dose to the middle. And if you don't have this structure to tell the optimizer, don't put too much 70 into the 60 gray, you may end up with some dose bridging here. And these are some formula we generally use just as a reference. Every institution may have a little bit difference here. So we would create optimization PTV that crop out 70 gray PTV plus a margin. The margin need to be with the distance enough to cool from 70 gray to 60 gray. And in our institution, we usually say head and neck, we are hoping our dose fall off is 300 centigrade per millimeter. So if you apply this, you will have like 3.3 millimeter distance is needed to cool off the dose from 70 to 60. Then we'll use 4 millimeter margin to create this optimization structure. So how does it do in action? If you just optimize without the cropped structure, this is how your dose distribution look like. So you get good coverage. So there's no problem with your coverage on the chart. Number will not look bad at all. But then you do have this effective dose of 66.5 into the 60 volume, which doesn't look nice, and it's not what MD intend to have in this 60 gray volume. So when you have this optimization structure to build a wall and tell the optimizer nothing more than 60 gray touching this area, 70 gray touching this area to push, kind of build a wall to push the hurdles in this area. So you will end up with more conformal dose, okay? And you won't have the dose bridging like this. And this is our planning 101 that all the planner will follow this rule to get a better plan. And OER objective wise, you will try to meet the OER, but you usually will just insert OER goal based on what MD prescribed for OER dose. But whenever there's an OER overlap with the target, then OER objective should be much smaller in the respective tolerance. The goal for the OER dose is ALARA. So what does that mean? Is it's not feasible to, let me take an example. If you have a tumor, you treat 70 gray and your priority gland right next to it. The national guideline will tell you the priority gland cannot have more than 26 windows, but then it's right about in your target volume. So if you include this overlap area for the optimization, you will end up with very infeasible plan because they are conflicting. In one hand, you tell the optimizer cover the entire target, and on the other hand, you tell the optimizer don't go more than 26 windows to this volume. So sometimes you do need to contour the overlap separately to tell the optimizer, I know this part is overlap, so don't info 26 windows in this area, but outside this area, info 26 windows. So that's a common approach to solve this kind of conflict of objective in the head and neck planning. And putting action. On the right is a common like prescription form from the doctor. You have the coverage prescription and you have what to meet for OER doses. And you do want to verify your objective, or especially when you are checking the plan or you are planner, try to make sure am I meeting the goal? You do want to check what you have in the optimizer is roughly following what MD asking for you to do. And you do want to make sure your ranking or the priority of the optimization objective is kind of created according to MD's request. So it's highly recommended MD to rank a clinical goal. A lot of times it's not practical at all if you tell them to give you the clinical goal for every single case. So how we do it is we have a departmental guideline, have a general ranking of the in each disease site. And if MD follow the general ranking, they won't need to do anything. They just drop the form in and they'll tell us what the importance is. And they only need to tell us when they are handling special case, like, oh, in this case, the patient is so young, I really want to push the priority gland dose as much as possible, and he will change it. Otherwise, if you spend the effort one time to clearly ranking your general preference of the trade-off and the importance of OARs, for most of the time, you don't really need to change it. You only need to change it for special cases that make it more practical. Okay, and here is one example that MD gives a prescription and MD tells the planner, hey, I know my brachial plexus and submandibular gland are kind of closed. And so the MD says, well, focus on the SMG and the brachial plexus more than in PTV coverage. So the MD clearly tells sacrifice the coverage as needed in order to meet this mean dose 9 gray for the submandibular gland and 68 gray to the brachial plexus. So when the physicists review the initial chart check and find, well, it's actually quite achievable. I know 9 gray is low, but 66 9 gray, there are like 5 cm, you for sure can cool it off to 9. And yes, I know it's overlap, but MD actually asking for 68, not 66. How come I still get like 92% PTV coverage? Then the physicists look into the optimization goals and find all the OAR are optimized with equal weighting. Despite MD clearly tells these two are way more important than others, but all of the OARs were optimized with 50 weight. So without changing any other thing, just increase these two to 90 priority, we actually got both the coverage to 95 and all the OAR sparing being compliant. So be careful. You do want to make sure your optimization is created based on what MD prefer the trade-off. And that will overall get you a good plan much faster, more efficient than I just load the template and go. Okay. And then investigate the contour structure that's not penalized. And that can be an oversight, like MD forgot to tell the planner. Like the example I told you, like what happened in our clinic last week, we almost give a high dose to the spinal cord because MD didn't really specify that OAR in his form. And then because it's loading like this part of the template for the prescription. And the planner was thinking, well, yes, just focus on the brainstem, so miss the spinal cord. Unfortunately, still within tolerance, but it's just not good. So it can be just strategically or just it can be an oversight. And then it can be intended. And so you really need to know the reason why they are not included. As long as they are kind of close to your treatment area and you do want to make sure you have something in your optimizer that you can address the dose there. And investigate the conflicting objective. It could be a mistake, and oftentimes due to the competing goals, like I want the coverage, I want to spare, how to balance it. And I found more often is the skill level of the planner. Once you have a good general strategy to tell your planner how to handle that situation, you actually see more consistent way they handle it and less miss of the conflicting objective. And so that's why it's important to know which one is more important, to know how to crop it. For example, if you have overlap priority gland in your target, one way to handle it is you can crop the target out from the priority and only push the priority gland like outside your target to say this part is reasonable, push this part to 20 or even like 20, the guideline is 26, and you can say, oh yeah, this part is far away, you can do 20, and that will help you to really shape the dose better and there's no conflict. Okay, and overall you may be still meeting around 26 because there are some overlap and the other party do push it lower. So this kind of similar concept as the SIB. And I found head and neck is really the side you need to do a lot of thinking about how you balance your coverage and your sparing with some technology like cropping or planning structures. Okay, last one is the dose gradient tool. We do want to emphasize this a lot for the TPS because nowadays all TPS provide you some kind of tool to quickly get to a very good plan. The concept, it will be like concentric rings or normal tissue objective, and in monocle you can also use body and quadratic overdose to and crop from different dose level. That will give you similar effect as ring. The caveat is regardless the technique, the setting matters. I'm showing you a clinical example. So when we got our Eclipse TPS, the trainer came to our side and told us, wow, this NTO is fantastic. You can just turn it on, even use automatic, you get a good plan. So a lot of them start from, I just turn it on and I set it very high weight to tell. And so when you set up as automatic, you actually don't see this fall function at all. You just say automatic at 100. So a lot of people just start from doing this and say, well, it looks good, but not perfect. And what's going on? You will only see what automatic means when you click on manual. Then you will see that those fall function is like this. So when you turn on automatic, the definition is more closer to like prostate type of dose fall off you are expecting. But with head and neck, you do want it to be tighter. So with the same plan, nothing changed. I just changed my NTO setting to, I want the dose fall off to start from 3 millimeter from the target, from 95% all the way to 30%. And I want this type of dose fall off. So this is very visual. As you type in different number, you see different fall off. So this is the only thing we change. And then I can cure the dose distribution quite a lot just by using this tool properly. Here comes our pool number 4. Which part of the plan can be further improved? So it actually didn't violate anything, but just by looking at the volume here, which part you think can be further improved? So there are 2 sides of target, and in the middle there is actually no target. This is really tight, 50-50.
Yes.
Yeah, good. All right, so let's move on.
All right. Yes, all in the pool.
This is a very interesting one, actually. I actually agree with both. I do believe that you guys probably mean the same thing. So this is acceptable plan, nothing really flag and nothing red in the plan check. But actually, the larynx was not included in the optimization. So that's why you can see the dose here is like 35 to 50-ish dose here. But if you just simply add very constraint, like say minimize the beam from here, even just a soft one can help you to cure the dose here. And yeah, similarly, you could also use the NTO. I think a lot of you guys talk about the dosing sharper, probably also refer the same thing. There is dose bridging here. Yes, but that is a little bit trickier, given that you do have both side lesions. And if you don't have a 90-ish degree collimator angle, even you tell the NTO to give you sharper dose, it probably won't be super effective. So it's a combination of beam arrangement and then NTO can also help you. So I do believe if you just have 90-degree collimator angle and tell the NTO to really sharpen the fall off between the two, you will also get a similar plan.
Thank you. We have a couple of questions.
Sure. I think we have time. Yeah.
Yes. How do you use GEUD for OAR?
Right. So we do use a lot of GEUD. Some of our planner, they even use OGEUD nowadays. So what you need to know is, let me see if I can draw. The GUD, regardless which TPS you use, is similar concept. So there is a number you need to put in, the dose, and the alpha or a parameter. So basically, let's first talk about the parameter. The parameter actually tells you which part of the DVH curve is working on. So it's like one equation, one setting. Just by altering the alpha number, you can do different things. So if you use a large alpha number, 20, for example, that means you want to push the tail of the DVH. And then if you use 1, that means it's everything. Okay, that means the mean dose. So if you understand in this way, it's actually trying to do the same thing as your conventional mean dose, upper, lower, but it's just one formula, one presentation to take care of a lot of things you need. Okay, so number one, to control which number to use, then depending on which part of the DVH you try to control. Different TPS give you slightly different definition, but in general, that's what it means. It can be if you just want the max dose or the mean dose. But the tricky part is the D, because I personally have the difficulty to find a better D to use at the beginning, because in the traditional optimizer, if you want core dose to be 45, you tell the optimizer core dose 45. 45 is the number used, but with GUD, since it's working on the entire area, not a specific point, you do want to make sure you have appropriate number, and you need to have a little bit experiment to know if you need to go higher or lower. In general, I'm taking that 45 as example. If I say I'm working on this part of the DVH curve, I want my core to be 45. If I put 45, I will end up with 50 as my max dose, because it's working on the entire portion of the core, the tail. So instead of asking for 45, if I get something that's 40 or even 37, then I will be able to get the tail to be 45. So D is the one I usually need to experiment a little bit to find a better number to use. But the alpha concept is probably straightforward. And I think it's probably because of this, it's a little bit different. A lot of people, they actually don't like to use this because it's not straightforward. But once you got the idea worked out, it's actually pretty powerful and make your optimizer look very clean. Every OAR is 1 or 2 lines. Yeah. Does that answer the question?
Yeah. What are the structures you use EUD? Do you use EUD for all OARs, or are there certain structures that would benefit using this?
So I personally prefer to use it for the max dose because it's more effective and it actually has some flexibility for the optimizer to kind of work around this area. And then mean dose, well, you can use it for all of them, because we do have planner use for all of them. But if you are adjusting yourself from conventional planning to GUD planning, I think start from max dose, you will get more feeling, more sense about GUD, and gradually you'll become all GUD person. Like now I'm more all GUD person. I just adjust the parameter. Yeah.
Okay. Another question is, what's the best parameter to do this manual NTO?
Oh yes, that's site specific. So for head and neck, like I showed in the prior, I need to clean the whiteboard, right?
I think you can just go back and it's gonna wipe.
Okay. Oh no. Yes.
Oh,
So head and
there,
neck,
sorry.
this, yes, yeah. I think there is a button to clean or annotate. What? Yeah. But this is in general what we use for head and neck. And this is in general what we use for the prostate. And then in the SBRT lecture, there is also shared paper about what to use in SBRT. But in general, I use this pretty much for head and neck, or anything I need sharper dose for, I use this one. Yeah. So to me, I have just 2 sets. Yeah. And I know some people have different settings for different area. And then I personally adjust them a lot, even for a good starting number, I may adjust it based on what I need. A lot of time I start from priority, or do I really need this fall off, or is this even achievable? If that's not achievable, I will revise this to like 40% or change the fall off to be not as sharp. The bigger the number is, the sharper the dose you get. Yeah, but this is the one I use for head and neck. Yeah.
Yeah.
And
Thank you.
You can email me for more.
Yeah. And another question is, spinal cord, the maximum dose is 45 gray usually. And would you make it a little bit different if it's 1.8 per fraction, 2 gray per fraction, or 2.2 per fraction dose equivalent? Would you consider anything like that?
In the clinical setting, no. I know there are some paper tell you how what correction you can make to change it. So in the clinic, we do just use one number, and 45 is the contact number. And if in our institution, we use high tech, we use Dr. Timmerman's table, which is grade 3 toxicity, that get it higher to 52.8 instead of 45. So we do have some clinical reach out to us when they really need to go a little bit more than 45. They will email us and talk to us and think if this is reasonable to go above 45. Yeah, but you can use different protocol, and we don't correct for a slight difference, because the main thing is number of fraction. It's driven for the fraction, not like dose per fraction.
Okay, thank you.
Mm-hmm.
I think we can move on. Thanks.
Okay, yeah. And then to your question, you can just email me for some suggested number, okay? All right, so let's talk about dose distribution. We follow RTOG, and then you do want to make sure you choose the right dose calculation algorithm. Nowadays, most of us use like AAA or better algorithm, and then finer dose grid will increase the computational time. For head and neck, it's not a problem. Most of the time, you use 2 to 3. In our old CPU setting, we use 3 millimeter, but with the GPU, we do go down to 2. So it's large field anyway, so usually 2 or 3 will work. And in this video, I'm going to show like a general process how to review a dose distribution for head and neck. So here's a plan, and you see a DVH, and you see a step. That means that there's not a lot of dose bridging. First thing, we usually suggest to go from the hotspot. First, check if the hotspots are in the target. You do go multiple view of this, and set this is 105, and you can do 103 just to make sure they are controlled within the target. And then you do want to make sure your RX dose, your prescribed dose line, is kind of conformal. If they are not conformal like this, you do want to ask question why, and if the MD okay with this trade-off. So you can evaluate the dose conformality for individual dose level. This is 63 and 56. You do want to see that there is not a lot of bridging between them. Otherwise, you want to review the objective, make sure they are done correctly. And from there, you start to check the dose gradient. We usually like to start from lower dose and gradually increase it to those meaningful number. For example, 35-ish is something our MD use for the spinal cord constraint. So we do stop at around 35 and see if there's anything cutting through the spinal cord, and then or go upper and lower. And then this is more at thyroid gland or oral cavity mean dose goes. Then you can put it to 20-ish and see if you're overall sparing it well. And the shape looks good. There's no weird streaking. And this is how the order will help you quickly, systematically review and pick up the issue. And we do see in this example that the 70 grade is not super conformal, and I can tell you why in the next slide. Okay. So this follows the what I just described. You do want to make sure hotspot location is good, and then you do want to make sure your dose gradient is good for the head and neck. And then if there is any streaking dose, and you should be asking questions. So the LAR dose should be as low as possible without compromising the treatment outcome. It is not acceptable to stop optimizing when OR dose just below the tolerance, and as it will make it more challenging if the patient require additional treatment. So that's also why our core constraint, we revise from 45 to 35 as general, like when we push the plan. And then sometimes we do try to push to 25 or 30 if possible. And conversely, understanding the target may result in the recurrent or patient permission disease, which is devastating for the patient. So remember, the dose has to go somewhere. So you do want to make sure there's a good balance between your dose coverage and your sparing. And here's an example. There's no absolute answer why it's the perfect dose, perfect plan. It's all about what you need or what the doctor needs to treat the patient. And are you following the guideline? Are you following the MD's preference? Here shows a perfect example. Patient has a lot of issue of the face and the oral cavity area because of the disease related or things. And so in this case, MD contour a huge oral cavity. Volume is actually including the area he wants to control the dose. And ask us, try to save this part as much as possible because patient is in pain. We don't want to make the patient feel even worse. So although we see the streaking here, but it is acceptable because it comes from the fact we need to reduce this part of dose for the patient's condition. So this is the reasonable trade-off he's willing to make. So as general planner or checker, you really want to evaluate and investigate what happened and follow up with the doctor if this is a proper way to handle it. And the plain sum composite dose is similar to all other presentation. I think if you have prior treatment, multiple treatment, you do want to make sure you do a plain sum, you do a EQD2 evaluation. And again, just to emphasize again, the registration is very important when you create a plain sum, especially for head and neck. A lot of time we do need to create multiple plain sum for our doctor to evaluate the different OAR dose, like the optical nerve and the spinal cord. Usually we need two different registrations to sum the dose correctly. And there is the report you can follow to do this. Communication, I just want to highlight more and head neck specific communication issue. And in general, you do want to make sure the necessary information is communicated to the therapist tech to help maintain a high quality. For head and neck, commonly you may have shifts from simulation because to get a good head neck plan is not super easy. A lot of time you do need to adjust your shift a little bit to give you the best plan quality, and that need to be communicated clearly. Like that, if patient requires shift, also require extra time for the treatment. So if you need shift, document it so I'll tell the therapist immediately so they can review their machine slot, make sure they budget time for that. And on couch imaging protocol, do you do CBCT only or do KV? That's also important. And this is super important for the patient setup issue or unstable anatomy. And actually, this part of information should be all the way from the simulation to have good notes to tell the downstream workflow what are the more unstable things. Usually what we pick up at the planning or checking phase are small things like this image looks perfect, but can patient hold this position for this long? Or yes, you seem something I can plan, but can this patient really hold this position for the whole time? That's a common issue we need to address. And usually we tell the therapist first fraction, budget a couple more minutes to make sure they are stable. And then bolus is a frequent one that causes confusion. The common issue of that is what type of bolus, because there are so many options. You can do weight loss, you can do super flat, or you can do 3D printing, or there are like clay-like bolus you can build in at the seam. So you do want to make sure you document well which bolus, how it looks, and the location and frequency. And our experience told us it's super useful. You just take a picture at the seam. If you create the bolus at the seam, just take a picture of how the entire setup look like, how the bolus look like, and put it in the same bag, sanitize and put it in the same bag. That will help. If there's anything created from the TPS, then it's required to have a screen capture of the 3D bolus you created, clear in the document, a big page of that, how the bolus look like. That will be super helpful and super visual for the therapist to quickly know, hey, I still need to grab this. I still need to find that piece of device before I call the patient in. So anything visual and clear in their regular document the therapist will read will be super helpful. And when we use bolus, especially the one created during the planning phase, will require some kind of setup in the first fraction because it was not there at the seam. You create it, but then does that mean they need to cut the mask in the first fraction, which will take like 5 to 10 more minutes. And that's also something you need to communicate through, make sure your downstream workflow understand what needs to be done in the first fraction. Or sometimes you or the physician will be presented the first fraction to clearly guide the bolus placement to be correct. So this will be impacting the involved time. If you need MD to be there to make sure it's done correctly, you need to make sure you block out the MD time so the physician can be at the machine. And the planner and physicists need to make sure the bolus position can be reproduced daily. So I'm taking the nose as example. If we need to bolus the nose just this side, it's not secure to create a teeny tiny bolus here because it won't stay. It will just wobbly. Instead, if you just go over the midline and let it hang there, it will be way more stable than just doing this. So this is something the planner and the physicist can actually review and evaluate the planning phase. Can this be easily placed down instead of every day you need to guess 3 different times and type it 3 different ways and CBC 3 times to get it right? It has to be something you can put it on, tape it, and CBCT and treat. So that's very important with impacting your 35 fraction patient experience. And if there is anything more superficial, a lot of time MD may want to know the dose, the in vivo dosimetry may be needed, and that need to be communicated as well. So incident learning wise, we want to make sure there is no accident. And there are some common process review in the head and neck treatment. First is the start date change due to the schedule of the chemo RT. That's a very common issue. The chemotherapy told us they move the time or patient has to start this day, this time. That will impact your start date. A lot of times, if they forgot to tell the planner, it can be delayed, and that's just unnecessary. And bolus placement issue is also another common process review for head and neck. And plan delivery time take too long, you try to focus on the paper good plan, and that can result in very long delivery time that's not favorable either. And then communication issue between with the patient setup device. If you make it too complicated, maybe give you a good plan, but it can be very error prone because if there are 10 different things they need to grab in order to get a good setup for the patient, it will be vulnerable actually. When a mistake happens, just acknowledge, investigate, and learn from that. And the formal instant learning system is highly recommended because you're gonna learn so much from having that centralized system to track what happened in different disease sites and hook up a better way to treat your cases.